Swayam Prabha. Digital India. Educated India.
Hello everybody, welcome back to this next module of Precision Oncology course. We will be going ahead with this module, the cancer detection methods. So till now we have really seen, we have got an idea about the whole basics of cancer biology. We really went about what about tumor suppressor genes, and what are oncogenes, then what are the different hallmarks of cancer, and what are the molecular mechanisms of carcinogenesis. So till now we got slowly introduced into all the concepts of oncology, molecular oncology, all their basics. Now what exactly is cancer detection? How do you detect a tumor mass or a tumor inside? What are the different methods available? Before we go to this whole module, I have structured into two sessions. In the first section, we will be really talking about the basically the screening strategies. What exactly? Why do you have to screen for a cancer? And what are the different? How does the governments adapt their different policies? You know, it's not necessarily like, you know, first example, cancer is like an overall disease where it's not only for specific to one country. It is like for throughout, right? How do the low income group low and the middle income group countries, how do they go about with their cancer screening policies, and how do the rich countries? So what are all the different population based screening? For this today's session, so basic terminologies of with respect to cancer screening I will be giving up. Now, as I said, you know, this is your why do we have to screen for cancer? Now, the worldwide cancer burden is very much likely to approach to 27 million. By 2040, they are expected to be 27 million new cancer cases, which is up from 18.1 million cancer cases, which was estimated in 2018. This, and here the major, the low income group countries are really, and all this particular regions, you know, they are all playing a very big role in this increasing the numbers. Why is this particular high interest? First, the population growth, aging, and changes in the prevalence of risk factors, they all contribute to this increasing in burden of cancer. Now WHO, it's like, now it is like it has to says that we have to hasten efforts to ensure healthy lives, and there is a promote for well-being. That is like you have to go for screening or preventive, go for vaccinations, for example, for places for cancers like cervical cancer, your HPV vaccination. By the end of the year 2020, the WHO, in its World Health Assembly, that it has to make all initiatives that will reduce the number of premature deaths of cancer by 1/3. So, for first here, this is the estimated age standard mortality rates in 2020, where in all cancers, and in all when you take across all both sexes, males and females, and in all and at all across all ages. It's like, you know, the cancer incidence is like the estimated number of in India for the year 2022 was found to be for this much, such a high number, that is approximately 100 per every 1 lakh. So there is in India, there is every chance that 1 in 9 people are likely to develop cancer in their lifetime. So if you see here, you know, the lung and the breast cancers are the leading states of cancer in males and females respectively. So among the pediatric cancers, you know, you have the lymphoid leukemia which is in the lead. So if you see in the males and females, see if you can really see what are the different, like the lung, the oral, the prostate, the stomach, esophagus, larynx, the liver. This is all they are all the cause of cancer deaths. Whereas in females, you have the leads as per the breast, the cervix, then you have the ovary, and even the lung, which is also coming much leading also, which is much higher, getting close to in this particular bar. This is the way how the statistics go about it in India. Now, how can you prevent this particular alarming rise in numbers? Now we come to let's say introduce another term called the cancer screening. It refers to a routine periodic testing for signs of cancer among individuals who have no symptoms per se. But of course, people go, even if they find a lump or and all, they go to the tertiary or the primary healthcare centers. So, in the context of the cancer screening, the goal of this, it is like secondary prevention, like can you improve the outcome of the disease. If a person, if he is diagnosed early, that is like you are shifting the stage of diagnosis to one that is less advanced, and you detect the cancer in its early stages. Suppose if you go for a cancer screening in the late stages, maybe it is very tough to further cure. This screening modalities, it has only a true benefit when it is like it should be not within your very high end screening only, not only in a perfect hospital, or it should be, a screening modality should be reaching the general population. So, if you can really reduce the number of deaths in this particular scenarios, it will be a very good success. Now, can you detect cancer? What is cancer screening? Basically, it is a sorting process. The screen is, the people are usually, they are positive, for example, cervical cancer, or they are like negative for this particular cancer. Whatever the particular test you find. So, the negative test finds nothing suspicious, you do not have cancer. It does not require any medical intervention. For example, you have a mammogram. If it's a lady is negative for mammogram after an age of 40 or 45 plus, then come back after 2 years for again another mammogram. It is nothing to worry about. Whereas a positive test, if it shows something, it is suspicious for cancer with unknown significance regarding it, requires additional medical attention. If they find a lump, or maybe if they find any lymph node size increase or anything, it has to be monitored. And another very interesting term here is active surveillance, where watchful waiting. It is like you schedule a minimally or a non-invasive testing to monitor for clinically important changes. So, now again, suppose if there is a tumor, or suppose there is if you want to resect an abnormality, it is also called, and this can be for example, a tumor lump is surgically resected, and it can be considered for diagnostically. So, maybe you take a biopsy, a fine needle biopsy, fine needle aspiration cytology, rather than treatment. It has to be definitely confirmed. So, main responsibility of any cancer screening program is to give a very conclusive or a confirmed diagnostic if it is a positive or a negative test. This is a simple algorithm of how the screening goes. So, it's like just take a population of, for example, a cervical cancer screening. You go to a community and you say that you want to do, how do you go? It's not, they don't seem anything abnormal. So, just they seem apparently healthy individuals. This is like you could conduct, for example, you go for an HPV testing or a pap smear, then either it's an abnormal, it's negative, or it is like a negative test, or it will be normal, it's negative test, it's normal, nothing to worry, just go back home. But whereas if it's something you find any abnormal in your, for example, if it's an HPV positive, you go for the diagnostic tests, further more set of diagnostics tests. Then if they have a disease, simple they go for treatment, chemotherapy, radiotherapy, whatever the treatment regimen goes at. And if still they do not have a disease, or maybe it is just very much a lesion which is of benign in nature, just keep watching for that. Again, come more regularly for a particular screening procedure. Before we go into the further depths, so I would like to cover here the different staging procedures. This is a very standard TNM staging system. This is a very standard terminology given, where your T refers to the size and extent of the main tumor. Wherever, so for example, the breast is a primary structure, the main tumor is usually called the primary tumor, and refers to the number of the nearby nodes that have cancer. This is simple, that is a lymph nodes, nearby lymph nodes. M refers to the cancer metastases. The T, again your T's, the clinician will give in the following terminology. Your Tx is the main tumor which cannot be measured. The T0, the main tumor which cannot be found. The T1, T2, T4 refers to the size and to the extent of the main tumor. The higher the number after the T, the larger the tumor or the more it has grown into the nearby tissue, simple. So, T is again maybe further divided into much more details such as T3A, T3B, like that. And your regional lymph nodes N, where cancer in nearby lymph nodes, where NX is like it cannot be measured. N0, there is no cancer in your nearby lymph nodes. N1, N2 and 3 refer to the number and location of lymph nodes that contain cancer. The higher the number after the N, the more the where the cancers could have metastasized. As the distance metastasis is M. Mx, where again your tumor metastasis cannot be measured. M0, cancer has not spread to other parts of the body. Where all this can, usually this staging is done by a PET CT. All this methodology and all that I will discuss it in the next session. But before, just to get this session, we will brush up on what are the terminologies for your cancer screening, or if you get a report or a PET CT report, how do you interpret or talk about it. M1 is cancer has spread to other parts. And something here again which we have is your stages. What is this? Suppose they say it is stage 0. It is like your abnormal cells are present but have not spread to the nearby tissue. It is also called carcinoma in situ or CIS. Stage 1, 2 and 3 maybe also be either you write it in Roman numbers or in the regular Arabic one, where cancer is present. The higher the number, the larger the cancer tumor and more it has spread into the nearby tissue. And when I say stage 4, it is spread to the other parts. So, few more terms is in situ, where abnormal cells are present but they have not spread into nearby tissue. Localized, where cancer is limited to the place where it started with no sign, but it has not spread, it didn't spread, it is a localized. So, regional, for example, the cancer has spread only to its nearby lymph nodes or to tissues or to organs. For example, again similarly distance, which has spread to metastasized all over to distant parts of the body. So, there is unknown, there is not enough information to figure out the stage of the cancer. One more simple screening methodology, it is like according to the recommendations, like the tumor size. First example, it is like a tumor size is it's a very, suppose you have a larger tumor size in your PET CT or in your MRIs or in your CT scans and whatever, it is usually it's the first thing you define a defined biomarker. First biomarker, I will tell you what is exactly a definition of biomarker. It's like, it's a variously of the tumor, it is like you talk about the tumor size, tumor diameter, tumor volume, tumor mass. There is a first defined biomarker for the efficacy of your therapeutics. You have the, and this tumor size also, it could be very slight variation, some based on your different contrast agents and different protocols, they affect the precision of your measurement. So, every protocol it is to determine the tumor size also, it is also dependent on the tumor location. So, now just recollect back, it is like you have the 4 phases of cancer progression. Now, so recollect back, so it's like we have really discussed how the cancer grows, right? How we said how a single cell differentiates to cancerous cells, and then how does this cancer cells multiply further on to establish as neoplasia, then a tumor and then metastasized, right? Now, just very much in a lower grade of level of representation here is your 4 phases of cancer progression. Now, here first in the phase A, it could be cancerous. It's absolutely patient is totally asymptomatic and it is not detectable with your regular screening technologies or screening tools whatever available. Okay, when you come to phase B, still the cancer is present but the patient is still asymptomatic and it could be detected with screening. Now, coming to your phase C, here the cancer present is symptomatic. The patient may express some kind of symptoms, for example, if it's lung, in majority, don't confuse with the stages and the phases here, where the stage 3 people are present themselves, especially in India, because we don't go for a low dose CT scan. for lung cancer screening. How do they present? They come with cough and loss of weight and fever and all that, and it is already by stage 3 and 4 only they go for the patients presents themselves here. The cancer is here in this phase C is symptomatic, and then you have the phase D where it is like cancer, dead due to cancer. So here you are talking about cancer is present and more asymptomatic and not detectable by any of your existing screening technologies for that particular cancer. So, you have all these 4 cases. So, now only here, because they come here into clinical attention because of the symptoms which they show here. Now, where are exactly your screening methods or your detection methods, where are they coming? Here you just imagine a very fine line, and here, so before the progression to the phase A to B or between B to C is only when your screening technologies, or being it molecular methodologies or your imaging technologies or whatever, they are only the very much intervening tools to help a clinician decide if the cancer can progress or is what exactly the decision for intervention has to be taken place. So, it can be so it is like it could be a slightly clinically advanced, but it may not be detected by a regular stage procedure here. Now, this is a typical generic analytic framework for evaluating or screening test. So, for example, you have a target population. So, now you need to have different questions here. Does the testing, suppose if I test for example for cervical cancer, if I do a HPV testing, remember how we mentioned that how HPV screening and HPV viral presence, the DNA presence and the cervical cancer. If you really recollect a molecular basics in molecular biology of cancer, you would really know there how this particular viral infection is correlated to HPV cancer. So, for example, suppose if I do a direct women, for example, if I say all the women directly testing, does it reduce the, for this particular, does it reduce the mortality and the morbidity for cervical cancer? This is my number 1 question which I have to ask here. This is a very, so before I evaluate for a screening test, yes, it has been very well proved. For example, with this case your HPV testing, yes, if I do for HPV testing for screening for cervical cancer, yes, it reduces morbidity and mortality. And then go for test accuracy. Do I have a test accuracy? Is my testing accurate? For example, a mammogram, is it very accurate? Yes. Now, what is the target population and the clinical uncertainty? Target population, yes, I take all this particular women. For example, if it is for breast or cervical, or men for your lung and for whatever other scenarios. And again, age is also very important factor. Now, then another very much important, like have the target population uncertainty, then go ahead for testing. Diagnosis, whether I give them a positive, if I find high viral load, does it correlate? Then we further refer for further other array of tests for that particular cancer scenario, and then classification of your target condition. And then this is your, what is the impact on your management, I mean on or health outcomes. Can we communicate this particular decision per se here? Then what is the, so again, change in clinical decisions. So, are we going to treat them? Are we going to counsel them? Of course, you are going to definitely treat them, but are you going to counsel them further, or how do you go ahead with that? Then what are the treatment strategies, all that regimens and all that. Then what is then again impact of intermediate outcomes on your health outcomes. Then adverse events, what are this supposing if I have, am I going to have any other fine needle, other aspiration or whatever it is, do I have any, for example, if we go for biopsy, what are the other adverse effects, and what are the adverse effects of all this. For evaluating a screening test, for example, this is the genetic analytic framework which they have to undergo for bringing this screening test, which will reduce the morbidity and mortality for that particular cancer. This is how after the screening procedure is done. For example, you've screened 100 women or 100 men or whatever, a general population, for example 1000, for one particular test. How do you actually ascertain the disease status? If you have a true positive, then you have, it is like which is only positive when you compare it with your golden standard. Then you have the true negative when you compare it with your golden standard. So your false positives, and then you have your false negatives as well. You determine the sensitivity. How often does the test correctly identify the sensitive individuals with the disease? It should be able to pick up all the positive patients. And then specificity, you have all these different formulas. How often does the test correctly identify individuals who are not with the disease? So, you have the different screening program evaluation basis. So, you have the self direction, then you have the lead time basis, then you have your over time, you have the length time bias. What is length weighted sampling? It leads to the detection of cancers through screening that is expected to have a better prognosis than those that are not detected through screening. So, your length bias refers to the tendency of the screening procedure to detect slowly growing lesions more readily than your aggressive cancers. All this will be, I will be discussing further detail in this coming slides. So, now it is like this is for example your lead time. For example, it is a bias, it refers to the overestimation of the survival time simply due to the backward shift in your starting point for the measurement of survival as a result of early detection. Then it is like, for example, you do not screen. With screening, the lead time in diagnosis prolongs survival. Even if death is not, it prolongs your the survival, even if the death is delayed or not delayed. This is your lead time bias, what we call it here. It is the backward shift in the starting point for the measurement of survival as a result of early detections. Patients who were diagnosed earlier, they can seem to live longer even after diagnosis, even if the time they died does not, that is their endpoint, the time of death does not change. Because of this lead time bias, a 5-year survival rates are higher for early cancer stage cancer than for advanced cancer stage. That patients who are screened benefit from the they benefit from the screening and live longer. Maybe it is just that fact that it is like the disease is detected earlier. The tendency of the screening technology to detect smaller localized tumors proves that cancers are being found at an earlier stage of their progression, but not that also it is not like, suppose I have detected the cancer very early, it is not that the outcome of the of that progression will be necessarily be altered. This is your lead time bias. One more terminology which we will be using here is your length weighted sampling, which refers to the fact that the chance of the screen detection is dependent on the length of the time. For example, recollect your earlier figure where the cancer remains in phase B. Here the cancer, the indolent cancer, which is really not very active, it becomes, and this is your aggressive cancer. And because of that detect screening, maybe for example, which is detectable, and your symptoms, and because of your time, so it is detected, and the symptoms and diagnosis, it is detected, and then death is prolonged, or that is different. But whereas for an aggressive cancer, even though it is, it can't be detected during, because it's already, it would have shown up symptoms, it could not be detectable at the screening stage, or maybe it was like with an individual approach. So then it is like the patient screening tends to be, your screening is more helpful for detect more less aggressive cancers, and it can be more beneficial in those terms. Here patients diagnosed earlier can seem to live longer after diagnosis, even if the time that they die does not change. Because of lead time bias, a 5-year survival rates are higher for early cancer, for early stage cancer than for advanced stage cancer, which by itself does not prove that patients who are screened earlier, that they who are screened, they benefit from that screening and they live longer. Only it may mean, it's like mean that the disease is detected earlier, that's it. But the progression of this cancer may not be really altered just because the cancer was detected earlier. The tendency to detect smaller localized tumors proves that cancers are being found at an earlier stage of their progression. It may not mean that the progression outcomes may be altered. So, keep in mind the detection and the progression of the cancer or the tumor is entirely dependent functions. Now, next comes to your lightweight sampling, which refers to the fact that the chance of cancer detection is dependent on the length of the time the cancer remains in your phase B. It refers to the tendency of the screening test to detect cancers that take longer to become symptomatic. Therefore, the more dull, more slow growing cancers. They have the tendency to become symptomatic only in the later stages. Not all cancers, they have the same behavior. Some are very aggressive while some grow more slowly. They are slowly, those which are growing at slowly, they are easy to detect because they have a longer symptomatic period of time when they are only, many of your screening technologies, for example, they are all like detected here. So, thus the screening test detects more slow growing technologies. So, thus the survival in patients with screen detected cancers is longer in part because maybe perhaps one of the reason is like your screen detected cancers are more, it could be they are less aggressive, or they can, the improved survival cannot be totally, it could be totally attributed to the early treatment and then a better outcome, clinical outcome, or it may not even be attributed that. This is what we called your length bias also. Now, coming to overdiagnosis. What is overdiagnosis? The detection through cancer screening of cancers that never would have been diagnosed in the absence of cancer screening. They could be very small tumors, they could be continued to be only in very low dull stage or inactive stage. That is like you go for you end up diagnosing for cancers that never would have been diagnosed at all. For example, there was no intention to detect, but it does not mean that you totally do not undertake a screening program. These are cancers that in the absence of screening would not progress beyond phase B. Recollect our earlier talked during the lifetime of the screening. The existence of for example, this particular overdiagnosis was once quite controversial because now they are some nowadays many people are coming to the open mind that some screen detected cancers may not are diagnosed unnecessarily. So maybe it because of this overdiagnosis. Overdiagnosis is basically an extreme form of your length bias in which a screening test detects, for example, here it detects a lung cancer that is really not, or a pseudo disease is a cancer but it is like it is a pseudo disease, a cancer which people die with, and it is not which they die with this particular cancer but not from this cancer. So, it may look like a cancer and to the under the microscope, but it could not have been really potential. When a screening test detects such a cancer, maybe we think we are treating the patient very successfully, highlighting the screening test to be very effective, when in fact so something maybe the screening test could have really not detected something, a really aggressive cancer. Maybe that particular tumor could have been totally highly non-lethal. This is all for example cases. We really do not know. This is one more term which we would like to have to pay attention is about your overdiagnosis bias and your pseudo disease. Now, for example, how this slide. So now first, what are the different elements of your organized cancer screening for cancer detection? For example, you want to bring it as a typical policy, or how do you want to have a perfect deliverable, what are the different this things. First, you have your leadership, governance, and your very, very important is your funding, financing for your cancer screening. This mostly happens in your Western, where a policy framework exists that describes the there is a complete policy framework which describes the your governance structure, your program objectives, for example, your cervical cancer screening, this many age women or this particular area. So you have your defined objectives, and then definitely it is very, very important to have your financial funding resource. And then do you have any of your, is this an evidence-based protocol, or is it a guideline that is universally complied with? Yeah, mostly whatever the universally compliant guidelines are really adhered to. How do you go for? Then how do you have a team? Do you have a hierarchy, structural team for implementation and coordination of this particular screens? For example, you want to screen say 20,000 women in this particular region or in this whole of state of Tamil Nadu or however resource. Do you have a proper program guidelines and implementations and well coordination? And very, very important this thing is you need to have health workers, when then and you need to have train this particular service providers, because they have to really counsel the women to be part of this particular. For example, the women could be totally from rural backgrounds, they could be highly uneducated. So now how do you, do you have to, it's a very, very important, and that too in their local languages also. It has this particular healthcare workers have to totally communicate if they are going to approaching in a rural sector or in a very low income country group. So now do this have access to your external services, such as your you need to have adequate infrastructure, for example, your electricity or whatever. You need to have a simple healthcare or maybe even a small healthcare unit. Do you need to have a provision? Is there for population education to improve awareness? This is very, very important part. So you have to improve the awareness, So for example, and it should be, there should be equity to access to screening of diagnosis and treatment services. We cannot say that only some people enter or no. It should be totally accessible to all. So for example, whenever it's an organized cancer screening. So now first then you have to identify the target population. So you will be inviting and recalling those requiring further. So whoever you have to enroll them in this particular screening program, and then so you have to make a provision for improving the awareness in that particular region. They have to have an informed choice. So and then you have to assure for that, then you will, after you invite them, then for informed choice of only to notify the result and inform only if positive. So a robust health system with a appropriate legal framework, it should exist so that it is capable of implementing invitation and call, recall, and also capture it has to take up all this particular programs, has to take up the data for program evaluation, full respect to very, very important part is your privacy, legalization and ethics, and it's a very ethical concerns. Then that, and you don't want to have like so people leaving your study in between, or like or recall them. Then information and system and quality assurance should serve should have a system to identify cancer occurrence, and the quality improvement framework with the responsible team should be available. This program should be evaluated with its own quality indicators and reference standards on your regular. When I say this program evaluation, you evaluate your screening test. Is it very specific? Are the health workers or whoever are helping the particular target population take up the screen test? Are they taking up the quality? Are they following the quality compliances, so that the test, you don't report any false positives and false negatives. A policy framework from the implement organization, which may be governmental or non-governmental. It should define the financial support, governance structure, goals and objectives of the screening program to guide implementation and evaluation. So, such training can be provided by the program or other stakeholders, and it should be regularly monitored. The legal framework is a mandate, to the appropriate. You need to protect the data protection safeguards and recognize a balance between fundamental rights of privacy and the access to healthcare. To clear defined balance has to be maintained. So, the regulation of the personal data, safety, cancer screening, registration and the linkage between the screening related data and other relevant data sources is necessary. It is very important to maintain for the cancer screening management, so that your national cancer portals, they can really access. For example, they can, whatever, if you make for the, look at the graphs what I have shown in the first things, only such registries, national cancer registries have to really access this particular data. The cost versus lives, yes, it is, of course the life is more precious, but you have there is an increase in health service cost, a patient out of pocket costs, there is a societal cost. Now, slowly we will now drift from the cancer screening terminology to a cancer detection, where we talk about here biomarkers. So, now what is exactly biomarkers? Biomarkers, they are defined as a characteristic that is objectively measured and evaluated as an indicator of a normal biological process or a pathological process or a pharmacological response to a therapeutic interventions. These can be measured by your macromolecules such as your DNA, RNA, proteins, or by cells or by processes, for example, that describe a normal or abnormal biological state in an organism. Now, the different biomarkers here is like, very general here I am talking maybe, but all in detail we will be taking forward in your next session. Here your tumor size, where, for example, it may not have if does it have an analytical validity? No, but there are numerical trials which qualifies it, even though they are inconsistent, that on tumor shrinkage and clinical benefit. So, for current data do not support its use as a surrogate endpoint. Then your C-reactive protein, which has where many high sensitivity tests are available, RCTs and observational studies are available. So, coming back to the real one of the very important detection methods for cancer is your molecular diagnostics, where you have your it's an application of molecular biology techniques for diagnostic, prognostics, or for therapeutic purposes in molecular for oncology. There are several major avenues in cancer medicine which utilize molecular based testing. For example, testing for your hereditary cancer syndromes. So, for example, there are a number of predictive tests involving either the analysis of individual drug targets or identification of specific tumor phenotypes which aid in the choice of your cancer drugs. So, monitoring of your malignant disease can be achieved through molecular driven detection of your residual tumor fragments. It is anticipated that liquid. Now, you have your what is called your two more terms which I have to introduce here is your FFP, fresh frozen biopsy ones, and then your liquid biopsy, which is your blood, which is where a lot of this molecular diagnostics for cancer are moving in that direction, and I will really tell everything in the detail in the next class. So, recent developings in your tumor mutations, for example, monitoring of your malignant disease can be achieved through molecular detection of your residual tumor fragments. Now, recent developments like your RNA analysis, like your mutation testings, and then your RNA analysis, they all offer proper novel tools for diagnosis of cancers of your unknown primary origin. When this, so you have something whenever this molecular diagnostics is applied to by the pathologist and then by the surgical people, we have this terms called such as molecular surgical pathology or molecular cytopathology, all that will come into play. So here you have the different predictive markers like your molecular targets. You can be like your HER2, EGFR, AL-cross. See, all this we will discuss in the coming in detail in your coming session. Then you have the tumor phenotypes, your mutation burden. All of them, they are the predictive markers, you know, which are very important biomarkers during the therapeutic journey for the cancer patients. So, like diagnostic tests, for example, you know, genetic tests are performed in FFP materials to confirm or exclude an inherited origin of the cancer. So, they are the so-called therapeutic pathology or like personalized therapeutic test. For this is called personalized therapy. So, cancer molecular tests usually are divided into mainly diagnostic, genetic and the therapeutic. So, because diagnostic tests are used because pathologists have difficulties in placing the right diagnostic label to the individual person. Now, the individual will no longer be only diagnostically categorized, but molecular categorization, which is very important. This is a very clear important term. For this is a very conventional therapy where you have patients where you had therapy, then they benefit, some don't benefit and some succumb or have adverse effects. Whereas here, you know, in the personalized therapy, it is like a companion. This is your, you have your companion diagnostic test, that is your molecular. You like, for example, you check for your driver mutations. This you check for your driver mutation, then for if I have this particular mutation, then the therapy changes. If there is no mutation, the therapy is a little bit different. So then you ensure that the patient benefits. So for example, your TKI inhibitors for your EGFR positive mutations for lung cancer patients. That is like now the prototype available in molecular diagnostic lab is like you have the analysis for all your driver mutations or for your microsatellite in the instability, for example, in your case of your hereditary non-polyposis rectal cancer. For example, you know, now to go back, you know, how can this molecular diagnosis really help, you know, how can the technology from the basic science, you know, for example, in 1998, you know, was so it's like more than 45 years after the discovery of your DNA helix, you know, there that particular director of the National Cancer Institute, he said, you know, it's like the molecular analysis technologies have to classify tumors, which have to give the molecular classification has to be very informative for the patient, for the clinician to improve on the therapeutics. This is a very ultimate challenge, and that is like, you know, you have your basic science discoveries which have happened, and the bottleneck is like how can the lack of technology or your lack of your robust research, you know, and the clinic and they all like, you know, how do they really help in giving a better, I mean, but how can you improve on all this particular bottlenecks, you know, to give a better output, you know, a better improved clinical outcome, you know. The glass, even though the for many cancer types, even still is glass empty, but there is a lot, this glass is empty actually. There is enough fluid to change that, there is a lot of scope to change the traditional standard of care for cancer with many of the molecular information. This, how can this particular molecular information can be in different scenarios has it been exploited to detect many cancer types? I will be discussing it in the next session. We will talk about in the next session the molecular technologies for cancer detection and cancer detection methods for different tumors. So thanks a lot. Thank you.